So my name is Samuel Giordano. I am an attending physician at Cooper University Hospital and an assistant professor of medicine at Rowan University School of Medicine. I'm a member of the Cooper Digestive Health Institute. I've been here for about 10 years. Within the Cooper Digestive Health Institute, there's about 14 other physicians that we work with, and we treat a variety of gastrointestinal conditions that range from gastroesophageal reflux disease or heartburn, some of that which we'll be talking about today. In addition, we also treat liver disease such as hepatitis, cirrhosis. We treat problems with abdominal pain, with inflammatory bowel disease such as Crohn's disease and ulcerative colitis, irritable bowel syndrome, as well as problems in relation to colon cancer and colon cancer screening. And we also perform procedures to help to diagnose some of those problems, such as upper endoscopy, colonoscopy, which is considered the gold standard in regards to colon cancer screening. So we're going to talk a little bit about gastroesophageal reflux disease today. And the first thing we're going to talk about is what is GERD. So gastroesophageal reflux disease is when somebody ingests a meal, you masticate or chew up the food, and then you swallow it down into your stomach. And in the stomach, acid is released to further break down the food. When the acid is released and the food particles are small enough, they then exit the stomach into the small bowel where further breakdown has taken place, and then later on, a lot of those nutrients get absorbed. So the issue in relation to gastroesophageal reflux disease, and in some patients when they ingest the meal and the acid's released into the stomach, sometimes, depending on the size of the meal and the amount of acid that's released, some of that acid may come up to the section where the stomach meets the esophagus, which corresponds to kind of like right under the breastbone. And the point at which the acid reflux causes symptoms is where we consider it gastroesophageal reflux disease. So the disease component relates to the symptoms that one experiences in relation to that. And those symptoms can range from a variety of different things. So the most common symptom that we consider in relation to gastroesophageal reflux disease is sort of the burning sensation. It may start in the pit of your stomach, radiate up into your chest area. Sometimes it can be associated with a sour taste in your mouth or sort of a foul taste in your mouth. So that's what most of us would consider the classic symptom in relation to gastroesophageal reflux disease. But there are other symptoms that can also signify reflux that may not be so intuitive. Some patients only experience abdominal pain, so they may have a pain in the middle of their chest there, or they may even have some chest pain, and even though it doesn't feel like reflux, sometimes that can actually be acid reflux. It's just that some people's nerves perceive it a different way. Other people can have a dry throat or a cough, and that may be the only symptom they have in relation to acid reflux. Other people may have nausea with or without vomiting. So those are some of the other symptoms that you can have that could signify acid reflux that may not be as classic as you would think of it, even though it may be slightly different than what you expect. And then there are also warning signs that could be associated with acid reflux. One of the warning signs would be trouble swallowing. So that if somebody is, eating their food, they have trouble, things getting stuck going down on them, or it feels like it's just not going down smoothly, or they have a unusual sensation when they swallow. Sometimes that can be related to chronic acid reflux, where it can cause a little bit of scarring and there may be a little bit of a narrowing there, or sometimes it could be something even worse, God forbid, such as a tumor that could be affecting the swallowing issue. So when someone experiences that, we generally recommend they be evaluated sooner rather than later to get that checked out. Other warning signs would be changes in the bowel movements, such as rectal bleeding or black stools. In addition, unintentional weight loss would also be considered a warning sign. So if somebody's eating as they usually would, they're going about their normal life, they haven't really changed anything, but suddenly they feel like their clothes may not be fitting as well, they get on the scale, they lost 10, 15 pounds, and they don't know where it went, that sometimes could be a warning sign that there could be something going on, and that's another situation where people would want to get that checked out. So all these things sort of are lumped into some of the signs and symptoms that may be related to acid reflux or gastroesophageal reflux disease. So the next thing we're going to talk about is what are the risk factors in relation to gastroesophageal reflux disease. So the main risk factor is unfortunately one of the most common things in the United States, and that obesity. So obesity is very common in the United States, and part of it, there's debate as to why that is, but some of it is related to how we go about our typical dietary routine, and where sometimes we tend to eat dinner as our biggest meal, where in other European countries, lunch oftentimes is the larger meal. So when you save the biggest meal for last, it sort of is the least active time of your day, generally after dinner. So when that happens, any excess calories that are consumed that aren't required for energy sometimes gets stored. And the most common way that our body stores that energy is in the form of fat. So when you eat the largest meal later in the day, then that can later on over time lead to abdominal obesity, which is one of the biggest risk factors in relation to acid reflux. And the reason that is that if you have increasing abdominal fat or abdominal obesity, sometimes that can push up on the stomach a little bit. So that if you're eating a large meal, or even if you're not, that pushing pressure or the increased intra-abdominal pressure on the stomach can lead to the pressure of the acid to kind of come up into the esophagus. Now, there are certain times in our life where it's not unusual to have episodes of acid reflux. One will be when we're an infant, when the gastrointestinal symptom is not fully developed. Then it's not unusual at that time to be associated with acid reflux or gastroesophageal reflux disease until it further develops. Another time, which is similar to the physiology of how obesity works, is that when a woman is pregnant and the uterus enlarges, there is increased intra-abdominal pressure, and it's not uncommon for women to experience gastroesophageal reflux at that time. So the first risk factor and the biggest risk factor is obesity. The second risk factor is related to some patients may have an anatomical abnormality called the hiatal hernia, which can lead to acid reflux. And what that is that when we digest food, the food goes down through our food pipe or our esophagus, and then it meets up with our stomach, like I said, roughly underneath the breastbone there. So what it actually goes through a muscle that separates our chest cavity from our abdominal cavity called the diaphragm, which has a little opening. And most of the time that opening is pretty tight where the food goes through. And so in those situations, the reason it's tight is to prevent the reflux of food contents or acid. But in some patients, that opening in the diaphragm is a little bit looser. And it actually allows the stomach to kind of slide up and down through that opening a little bit. And that's called a sliding hiatal hernia. And the negative of that is, one, you don't have as good of a mechanism to keep the stomach acids down. And two, in that if you were lying down too soon after you eat, or you eat late at night, since the squeeze mechanism isn't as good, then it's more common for patients with a hiatal hernia to get nighttime acid reflux or reflux in the middle of the night while they're sleeping, which can sometimes wake you up in the middle of the night. So the second risk factor, which is more of an anatomic abnormality that you wouldn't generally know you had or you didn't unless there was further evaluation to be done, whether it be an x-ray or an upper endoscopy test, which we'll talk a little bit more about, is a hiatal hernia. Then the third risk factors is related to stuff we do every day, sort of dietary habits, behavioral habits. There are certain dietary things that we do that can predispose patients to acid reflux. So one of the first types of diet things that can lead to acid reflux would be eating acidic foods. And that would be like orange juice, grapefruit juice, tomato juice, cranberry juice, pasta sauce, ketchup, things like that. Pizza, anything that has a red sauce on it or that's acidic in nature can increase the stomach acid contents that could predispose you to acid reflux shortly after consuming that particular meal. Another category is alcohol. So alcohol works by loosening the lower esophageal sphincter muscle that is down at the end of the esophagus, trying to also work with the diaphragm to prevent acid to come back up. And in some patients, alcohol can loosen that muscle and predispose you to acid reflux in the setting of alcohol. Caffeinated beverages is another one. So everyone's probably saying all the good stuff causes the acid reflux. So caffeinated beverages such as coffees, teas, sodas, things like that can predispose you to acid reflux. Nicotine, tobacco can predispose one to acid reflux. So those are some of the more common dietary things that we do that can put us at risk for acid reflux. And as far as behavioral things, and we alluded to it a little bit, but certain people eat late at night or snack right before bed, and the problem is that when we consume any food, even if it doesn't seem like a lot, like some people can have a couple crackers before bed just because they feel like it makes them sleep a little better. When we eat something, like the stomach acid gets released, and then right now when we're sitting up or we're standing up, gravity has an effect to keep the contents of the stomach down. So you don't have as much of an issue with that. But then at the nighttime, in particular in patients with a hiatal hernia, if we consume a meal right before bed and then we lie down too soon, once you lie back and you take that gravity effect away, then you can have the acid contents coming up. And you may not feel it right when you lie down, but like I said, if sometimes it can wake you up in the middle of the night, or sometimes right when you wake up in the morning, you can feel symptoms of nausea. Some people will even have to vomit in the morning. And so what I tell my patients is that if you have morning symptoms before you eat anything, it's generally due to nighttime behavior. And so some people can't control it as much if they're working long hours. They get in like 11 p.m., and they want to eat right before bed. But the goal in patients like that, I tell them to try to maybe eat the dinner at work, not eat as much before you lie down. And the general rule of thumb that I recommend is to try not to eat within 2 hours of bedtime. Try not to drink within an hour of bedtime in patients who have acid reflux, in particular patients who have hiatal hernias. And a lot of times they'll get themselves out of trouble from that standpoint. So those are some of the things that are risk factors in relation to the acid reflux, and that can contribute to patients who get acid reflux. So the next topic we're going to talk about is how GERD, or gastroesophageal reflux disease, is diagnosed. So the way that it's diagnosed, the primary initial diagnosis is based on a history. So this is where it's important in terms of the patient and physician relationship, that the physician really listens to the patients, lets them talk about in terms of what's going on with their symptoms, when they most commonly get it. Does it happen after they eat? Does it happen at night? Does it happen in the morning? Does it happen when they exert themselves? So all these things can better allow us to make a diagnosis to see whether or not it may be related to acid reflux, or maybe it's something else. For example, if somebody told me that they were having pain mostly when they exert themselves and it's not really related to food, then maybe that could be something that may be cardiac related, and I would then direct the patient to also consider getting a cardiac evaluation just to be sure that there may not be more than meets the eye and it may not be reflux, even though it may seem like that. But say somebody says to me, it's generally after I eat, or after they eat some of the things that we previously described, like maybe they were having some peppers and onions or pizza or something like that, and it's most commonly when they have like red pasta sauce, and some of those things could lead you down the road that it may be related to acid reflux. Or say they tell me it's always at night, or it's when I'm lying down for bed, or it's when I wake up first thing in the morning, then as I previously described, sometimes that can be a sign of acid reflux, and those sound more classic. So the first step to diagnosis of acid reflux would be having a thorough history, evaluation with the patient, going over the symptoms, seeing when it occurs, and that helps to kind of wean things out from that standpoint. The second step in diagnosis would be to try some therapy to see if it improves things. So for patients who have very mild acid reflux, meaning that it's infrequent, maybe once or twice a month, I generally recommend starting with behavioral therapy or lifestyle therapy to try to see if that works. So that would be avoiding some of the foods that we previously talked about, if possible, in particular nighttime eating of those types of things, like late having a glass of, some people have a cup of coffee after dinner, trying to avoid that, or maybe it's when you have a glass of wine, so you want to go easy on that. So the first step would be lifestyle modification. The second step, and this is mostly reserved for patients who have acid reflux, generally like 2 to 3 times a week, I would try a medication trial. And the medication trial doesn't have to be a long-term thing. It may be only for 6 weeks, to where I try out a medication and we discuss the proper medication to try for a 6-week period of time to see if it improves a patient's symptoms. It's important with the discussion to set up whether or not what the expectations are in regards to the medication improvement. So I tell patients that don't expect if I give you a medication that you're not going to have the symptoms at all. The goal would be a 50 to 70% improvement. So if you feel your symptoms are improving at least 50 to 70%, then that tells me there's at least some component of acid reflux that could be causing some of these symptoms, and then we can decide if you want to stay on the medication or you want to try going off, or whether we can just, sometimes patients can lose a little bit of weight, and sometimes that allows them to go off of the medication, and sometimes it may only be 5 to 10 pounds, but that can make a difference. So the second step in diagnosis would be a medication trial. And the third step, and this is reserved for patients who either have long-term acid reflux, and what I would classify that as either 2 to 3 times a week for 3 or more years, or patients who have the warning signs that we previously discussed: trouble swallowing, black or bloody stools, unintentional weight loss, persistent nausea, vomiting, or abdominal pain, things like that. Or in patients who have a family history of esophageal cancer, or they may have a higher risk factors in terms of their family history, then we would discuss doing an endoscopy to further evaluate that. And that's a procedure where we use a scope the size of my pinky with a little camera on the end. You're completely put to sleep for it. Only takes about 10 or 15 minutes, and we look down the mouth into the food pipe, into the stomach, and we get an actual view of the end of the esophagus there to see if there's any evidence of inflammation, to see if there's any evidence of damage or scarring related to acid reflux, or God forbid, to see if there's any evidence of like an esophageal cancer. So that would be the last step in patients who don't improve on the medication, who have long-standing acid reflux symptoms or have warning signs, and we would discuss that to further evaluate things. So those are some of the things we can use in the diagnosis to try to better wean out what the best step is for the patients. So I think next we're going to go to one of the questions we have. So let me take a look here. So the question says, so what is frequent, every day or week or a month? Okay, so I think I alluded to that a little bit. So the way I would consider frequent would be, like I said, if somebody's having acid reflux or heartburn symptoms 2 to 3 times a week, mostly every week, for 3 or more years. So to me, that's the point of significance of acid reflux. Now, if it's not been 3 years, but over the last couple months, somebody's having acid reflux symptoms 2 or 3 or more times a week, or 2 to 3 times a week, it doesn't mean that at that point it may be worthwhile to consider the medication trial like we talked about. So that's how I would approach that, because if somebody's only having it once or twice a month and you try a medication for 6 weeks, you may not get the window where people are getting symptoms with that. Whereas if you're getting the symptoms 2 or 3 times a week every week, and you do a medication trial for 6 weeks, you should really see if there's going to be a difference or not. So there should be some tangible evidence of a difference, and that's where I think the medication trial would be suitable. Okay, so all right, so the next step is, let's see here. What are the treatment options? Okay, so there's a few different possibilities in terms of the treatment. So most of the treatment, like I said, the first step in treatment would be if somebody can practice lifestyle modifications, then that would be the easiest way to do it. It wouldn't require medications, things like that. And that does work for some patients. As long as you're very deliberate about the discussion, you go over the specifics, patients surprisingly can do well with that if they're having mild symptoms. And we've alluded to some of those things, but that would be trying to lose weight, trying to avoid the trigger foods that we talked about. If somebody is smoking or drinking a lot of coffee or alcohol at night, trying to avoid some of that stuff. Trying to avoid the late night eating, snacking before bed. Some people, believe it or not, wake up in the middle of the night, feel like they want to eat something. So those are like some of the worst things you can do from an acid reflux standpoint. So if we can modify those things, that's generally the first line to try to do some lifestyle modifications. Now, in terms of the medications, that would be the next line. And so we alluded to when we would consider medications in patients, but some of the medications specifically go by pretty much 4 categories. The first category is antacids. So antacids are what we classically consider, what people take over the years in terms of like Rolaids, Tums, and these can even be natural things. Like some people are more into taking the natural stuff, and they may take like a teaspoon of baking soda or some apple cider vinegar. in the reality, all of these are acidic neutralizers or acidic buffers that help to regulate the acid. And they do good in the short term. And some people may get quicker results initially, like when they're having those symptoms. They're actually things that are good to use. The negative is that they don't last very long. They may last 20 minutes, 30 minutes, and the next thing you know, it's coming back, and you got to do it again. So it's not really a good long-term solution, and it's not a great medication for somebody who gets it more frequent. So if you get acid reflux once a month and it just happens you have a bad episode, it's probably not the end of the world to try taking a couple Tums, and that may do it by itself. But in somebody who has more frequent symptoms, then sometimes you have to consider something that gives you a little bit more long-term relief. So the next category of medications would be one of those things that give you a little longer term relief, and that would be H2 blockers. So histamine blockers are basically, there's several generations of those. So in the 70s it was Tagamet, that was sort of like the first generation H2 blocker, and then it changed into Zantac in the 80s, and now in the 90s it's kind of like the newest version is the Pepcid or famotidine. And some of these are available over the counter. And the general rule of thumb is that the over-the-counter dosages are about half of the dosages of the prescription. So if it's Zantac 150 over the counter, then the prescription dose is 300. If it's Pepcid 20 milligrams over the counter, then the prescription dose is 40 milligrams, or 20 milligrams versus 40 milligrams. So those medications work a little bit longer, maybe in the 6 to 8 hour range. And they give you some flexibility in that they can be used as needed. So once again, if somebody's only getting symptoms a couple times a month and they just want some, like they know they get it every time they have a glass of wine or they go out to dinner, they can then preemptively take like a Pepcid before that particular meal, and it may ward off symptoms that night. But it only lasts about 6 to 8 hours. So for patients who are getting it throughout the day or getting it more frequently, it's not always the best solution. But for some patients who only need a therapy every so often, it definitely works well. The last category of medications is called the proton pump inhibitors. And once again, those are available over the counter. There is prescription versions. Some of the ones that we're talking about is Prilosec, Nexium, Prevacid, Dexalon, Asifex. Those are some of the more common proton pump inhibitors that we see. And most commonly over the counter is 20 milligrams, the prescription is 40 milligrams. But those medications have the advantage of lasting longer, in that most of them can last in the 8 to 12 hour range. There's Dexalon, which claims that it can last 18 hours, but some of the other ones are about the 8 to 12 hour range. So I try to weed out when the patients are having symptoms. So if it's more common that these patients are having symptoms at night, then I'll tell them to take it 30 minutes before dinner. So these medications are better taken on an empty stomach before the meal, whereas the H2 blockers, it's not as specific with the food content. But with the proton pump inhibitors, somebody's having nighttime symptoms, I'll tell them to take it 30 minutes before dinner. If they're having daytime symptoms, I'll tell them to take the medication 30 minutes before breakfast, so that you're trying to maximize the most effective time with the time when you have the symptoms. And I have some patients coming into me and they're taking the Protonics 30 minutes before breakfast, but yet they're getting nighttime symptoms, and sometimes the fix is as simple as just switching the timing of when they're taking it, but it does have to be taken on an empty stomach. Now there has been some press lately about the proton pump inhibitors. I'm not going to go too far into this, but there's very little side effects to these medications. One of the ones that we know for sure is that it can decrease your calcium, magnesium, sometimes your iron absorption, because these nutrients, they are better absorbed in an acidic environment. So whether you're taking a medication, you're taking baking soda, you're taking Tums, if you decrease the acidity of the environment with which they're in, then these nutrients aren't absorbed as well. So we know for sure that calcium, magnesium absorption is less in patients who are taking these medications. So it comes into play mostly in postmenopausal women. Estrogen is pro-bone formation, so as women lose the estrogen formation, then their bone density can be affected by taking these medications long term. So in patients who need to take it, I just make sure that they're getting their DEXA scan, their bone density scans by either their OB or their primary, just to be sure their bone density is okay. If it's getting worse, and sometimes that could happen even without the medication, then they may need to be started on a supplement, or they may need some other medications to improve the bone density. Now, the other side effects that have gotten a lot of press, such as kidney disease, heart disease, dementia risk, those have been found to be possible associations, but they have not been proven. So there has been no demonstration of causality, meaning that this causes that. So although there's a possibility that will show it down the road, as of now, all that stuff has not been proven true. So the one thing is that it can affect the bone density, and especially in postmenopausal women, that needs to be monitored. As of now, the other things have not proven true. So I think we have a question coming up next, so let's take a look here. How long should it take to feel relief from longer term meds? So the question with that is, so the first thing you have to make sure is that you're taking it the right way. So so it's not uncommon for people to come to me, me being a specialist, they may have already been treated with this medication by their primary or by another doctor. It's not uncommon for me to sit down with them and then ask them how they're taking it, and they'll say, oh, I'm taking it after dinner. And then them not realizing exactly how they're supposed to be taking it, meaning that they should really, in particular in the proton pump inhibitors, they should be really taking it before dinner. So sometimes the fact that someone may not be getting relief may just be either the timing, like we talked about, if someone's taking it in the morning and they need it in the evening, to change it to before dinner, or if somebody's taking it after they eat. So the way these medications work is that they decrease acid release when you eat. So if you're taking it after you eat, then the cat's already out of the bag, the acid's already released, so it's not going to be as effective. So it'll decrease further acid release, but some of the acid that's already released is maybe causing you symptoms. So the first step in characterizing as to whether or not a medication is effective is to be sure that they're taking it properly. So assuming that a patient is taking it properly, I generally give a trial of like 4 to 6 weeks. So if somebody has been taking the medication for 4 to 6 weeks, doesn't seem to be doing anything, they're taking it the right way, it's still not working, that to me tells me either the medication dose needs to be escalated or they may need further evaluation, like we talked about earlier, with an endoscopy to kind of see and make sure there's nothing else that could be causing the symptoms. So that's sort of how I would answer that question. All right, so and then the last the last treatment option, although it's generally reserved for patients who either don't respond to medications or who have a large hiatal hernia from a size standpoint, would be surgical correction. And that would be something called a Nissen fundoplication, where the stomach gets kind of wrapped around itself so that it increases the width of that stomach section, so that even though the diaphragm opening, like we talked about, may be a little wider, now that the stomach is now wider with that surgical procedure, it doesn't allow it to come through. So in patients who have failed traditional therapy, they're not responding to the medications, or they have a very large hiatal hernia where they're getting like persistent vomiting after they're eating, it's sort of like a last resort, but that's the situation where I would discuss the surgical options, and we have surgeons here at Cooper that certainly can correct that. All right, so I think we have another question here. If my symptoms have improved, can my dosage be reduced? So yes, my thought, the way I respond to my patients is that I only try to keep them on medications if they need the medications. And once it's been established that they're responding, then I try to de-escalate the dosage. So say I put them on a proton pump inhibitor that's 40 milligrams, they're feeling great, they have no symptoms since they've been on it, then usually after they become stabilized after a few months, then I'll try to dose reduce. So instead of doing 40, I may try to decrease the dose to 20 milligrams and see if they can still establish improvement in their symptoms. The symptoms come back, well, they know they're probably going to need the 40 milligrams, assuming they haven't changed any dietary or lifestyle things within that period of time. Or in someone who say they get down to the 20 milligrams of a proton pump inhibitor, then I may try to de-escalate them to a Zantac or a Pepsid, which, like I said, isn't as strong as the proton pump inhibitors, but do have less of an effect on bone density. So say somebody comes to me, they're an 80-year-old woman, they have bad acid reflux, but they also have osteoporosis. I may try to get them stabilized from a reflux standpoint on an H2 blocker because I know it's not going to make their bone density worse, as opposed to going right to a proton pump inhibitor. So that's sort of so we usually try a continuum to try to decrease patients down from the full dose proton pump inhibitor to a half dose proton pump inhibitor, then the H2 blockers, and then you would go from the 40 milligram H2 blocker down to a 20 milligram, and if that's still working, then you could even just switch it to an as needed. Assuming they don't have any damage in the esophagus, then I'm fine doing that. Now the situation changes if somebody has damage in the esophagus, and that leads me into the next thing I want to discuss with you guys. So the last question is that can GERD, what are the concerns of GERD undiagnosed or unresolved for a long period of time? So I'm going to try to put it in simplistic terms, but I want to give you a little bit of background so you understand it better as to what can happen. So when we digest food, I mentioned this before, but we swallow food down through our esophagus into our stomach. The stomach acid breaks down the food. Now, the reason we don't feel normal stomach digestion is because the stomach lining secretes a mucus layer that protects it from acid. So we don't even know what's happening. The issue happens when the acid or the acid mixed with food content gets up to the level of the esophagus. Now, that esophagus lining does not have that protective mucus layer. So that's where it starts to become irritative, it starts to burn, it starts to give you some of the symptoms we alluded to earlier. So over years of that, the body wants to adapt to make it more efficient. So the body says, if you're going to keep allowing acid reflux to come here, I'm going to change the lining of the tissue cells of the esophagus into stomach cells. And what that's called at the pathology level or at the tissue level is called intestinal metaplasia. And that, in layman's terms, is basically a change from esophagus lining into stomach lining in the cells right in the end of the esophagus where the acid occurs. And some patients can have it a large portion of their esophagus depending on how bad the acid reflux is. The significance of that change is that when you change one cell type into another cell type, it leaves room for a mess up at the cellular level. And that mess up can be a cancer, an esophagus cancer. So in patients who have this change from one cell type to the other, that's called Barrett's esophagus. And that can be a precancerous condition. And once again, the patients that I'm concerned about that may be subject to that is if somebody's had acid reflux two or three times per week for 3 or more years. There are certain categories of patients that are higher risk for that, particularly Caucasian males over the age of 50 who are obese are definitely highest risk category for that. But it doesn't mean females can't get it. The youngest patient I have with Barrett's esophagus is actually 24 years old, but she's had acid reflux for 5 to 10 years. She has a hiatal hernia, so you can't always just judge it based on what the highest risk category is. It's all about the duration of symptoms, the significance of symptoms that can put patients at risk for this change in the end of the esophagus that are called Barrett's esophagus. So when patients have acid reflux long enough that they're at risk for that, that's a situation where we would discuss performing the endoscopy test. Because unfortunately, there's only one way to see if that's there, and that's to look at the tissue lining, see if it looks suspicious, because you can visually see a difference in the setting of Barrett's esophagus. And when we see a difference, then we can do a biopsy sample, and it's diagnosed through a biopsy sample. So it's not as if I can look and say it's definitely Barrett's. When we do that biopsy sample, the answer is yes or no. It's black or white. So somebody either has that or it doesn't. Once that change occurs, it doesn't go away. So it's a permanent scar, it's a permanent change, and then patients who have that need to be monitored. So what we generally do is that we put patients on proton pump inhibitors. So for this particular condition, patients need to be on a proton pump inhibitor for the rest of their life. Even though I'm not a medication person, that's a situation where I say you have to take the medication for the rest of your life, because that particular medication is the only thing that's been shown to decrease the risk of cancer progression in the setting of Barrett's esophagus. In addition, patients are typically screened with upper endoscopies every 3 years. That does nothing to prevent the cancer development, it just catches it earlier. So that if there is any change at the level of the tissue, that we do multiple biopsies in that section to see the earliest change at the tissue level. And if we detect that change, then we can do things to prevent that. So here at Cooper Digestive Health Institute, which has an association with MD Anderson here at Cooper, we have specialists who can do a radiofrequency ablation called Barrx. It's BARRX, where we can burn that tissue once we get the earliest sign that it could be going down the cancer road. We can then burn the tissue where it is there and stop it in its tracks. Now that still requires monitoring. By doing that, it doesn't mean you don't need to be monitored. It just means that decreases the cancer, the progression to cancer from the Barrett's esophagus substantially. So, and that's some of the stuff that we can offer here at Cooper. And that's why it's important to monitor these patients so that you can catch it at an earlier level before it gets to a point where you have cancer, and then the only therapy there would be surgical removal of the esophagus, which is a long, extensive surgery, which in some patients it's required, but you want to try to avoid that and be preventative as opposed to being reactive down the road. So I wanted to thank everybody for joining us today. Hopefully I answered some of your questions. Hopefully I gave you some information to think about. Obviously, if anyone feels like, you know what, so after I'm discussing this, they're like, that kind of sounds like me, or I have some of those symptoms, we'd be happy to help out any way we can. The phone number will be at the bottom of the screen. You're welcome to call myself or any members of our division to make an appointment to go over this further. We're all qualified to help in this situation. Or if you have something unique that may not fit into the categories of things that we talked about that's bothering you from a gastrointestinal standpoint, we'd be happy to help in any way we can. It's nice to speak with you, and please, we look forward to see you.